This video will provide an overview of documentation in pediatric PT, and we're going to specifically focus on natural environments, so providing therapies in schools and early intervention settings. And so to give you a little background, physical therapy is provided to children in schools and early intervention settings under the Individuals with Disabilities Education Act, or IDEA. Part B of IDEA provides special education and related services for children ages 3 through 21. And Part C provides developmental family-centered services to children aged 0 to 3 in natural environments to promote development and participation in daily activities and routines. So looking at this, Part B is really our public school services. This is where we see children in public school settings, whereas Part C are infants and toddlers that we see in natural environments. So that includes the home, daycare centers, maybe a community park, and those types of environments. Looking at these a little bit more closely, IDEA Part B provides free and appropriate public education, or FAPE, for children aged 3 through 21 years. And we often think of public education as being provided to children ages 5 through 18, which is more typical for children that don't require special education. But IDEA, special education law, actually allows for children to receive public school services beginning at age 3 and to stay in the public school system through age 21 years if they have special education and if they desire to do so. Services must be provided in the least restrictive environment, which means that to the maximum extent appropriate, children with disabilities are educated with children who are not disabled. Children receive related services. This includes PT. Related services are provided as may be required to assist a child with a disability to benefit from special education. So it's important to remember that in the school setting, PT is a related service. So all physical therapy services and documentation must be provided to assist a child with a disability to benefit from special education. So everything must be educationally relevant in this setting. Under IDEA Part B, children also are entitled to receive assistive technology, and the plan and services for the child are all documented in the Individualized Education Program, or the IEP. Now there's a model IEP form at idea.ed.gov that shows what an IEP may look like. So if you want to see sort of what an IEP might look like, I'd suggest that you go to that website. But just a few things about the IEP. The IEP is developed by the team, and the physical therapist is part of that team. So it's usually done at a meeting, and the team may include special education teachers, regular education teachers, of course the parent, sometimes the child, related service providers, and other representatives from the school or other people that need to be on the team. The IEP is reviewed and rewritten yearly, so all goals and documentation in the IEP are really meant to carry through an entire school year. So that's a really different perspective than more medical settings where you may be writing goals and providing documentation for, a few weeks or at most a few months. And in this case, you're actually looking at writing goals that are going to be over a year's time. The IEP must include a present level of performance. It must include measurable annual goals. Short-term goals and benchmarks are actually not required under federal law. It must include a description of how progress towards the annual goals will be measured. So this may be through testing, through checklists, through observation, through teacher or therapist data. All of those may be ways that progress will be measured. It must include a statement of special education and related services that will be provided, and also a transition plan for children who are age 16 and up. And in addition to all these things, the IEP must also include an explanation of the extent to which the child will not participate with non-disabled peers, a statement of accommodations necessary for state and district-wide assessment, as well as a projected date for beginning of services and modifications, frequency, location, and duration of services. So if you are a PT providing services in a school setting, you're going to have to give that input into the IEP of how often am I going to see this child, and where am I going to see them, and for how long. So it's important to remember as a PT that we have an important contribution to the IEP, but we have to understand that in school settings, again, we are a related service. So everything we do must relate to educational needs and be, quote, required to assist a child with a disability to benefit from special education. A motor delay or disability does not necessarily qualify a child for school-based PT. Once the child meets the criteria for special education, the team determines whether the child needs the unique expertise of a PT to be able to access and participate in his or her education. So we really look at how the child is participating in their school environment. And it's important to note that, sometimes children may have medical PT needs that are not addressed in school because maybe those needs aren't actually impacting their education. And the flip side is that the child may have some needs that are impacting their education but may not be relevant for a more medical model therapy. So these are really two different philosophies, and a child can be getting both types of services. But we really have to be thinking as PTs, always making all of our treatments and documentation really educationally relevant. We are going to help contribute measurable annual goals, and so we may submit or contribute our own goals that are more specific to gross motor function and mobility, or we may just be part of the team that puts together more broad goals, and then we figure out how we can use our expertise to help meet that goal. So for example, the team may put together a goal that the child will participate independently in lunchtime, and then as PTs we may think, well, what we can do in that setting is we can help work on their ability to carry their lunch tray without dropping the items on the lunch tray. And the IEP under federal law does not require short-term objectives, but some state practice acts may require short-term objectives, and we also may want to, just for best practice, keep our own short-term objectives. So even if those aren't part of the actual IEP, oftentimes therapists will keep sort of supplemental documentation where they may have short-term objectives that are meant to be met, on a monthly or quarterly basis. So how do we come up with the annual goals for the IEP? Well, we first want to kind of come up with outcomes that we get those from the child and parent. So we ask the child or the parent, what do you want? We may collaborate at team meetings and just come up with outcomes, just some general ideas of what we want. So these outcomes aren't necessarily measurable, but they must be functional. And then they become the basis of our annual goals. And our annual goals is where we kind of take those outcomes. So the outcome, may be, I want Johnny to get off the bus by himself. And we create measurable, educationally relevant goals to be achieved within the school year. So that's when we may say, Johnny will walk down 4 bus stairs holding a rail without falling 3 out of 4 days per week. So we've taken that outcome, that kind of general, not measurable outcome of getting off the bus, and made it into a measurable annual goal. Now, as I mentioned previously, short-term objectives are not required by federal law, but they are necessary under best practice and should usually be developed by physical therapists. Even though these are not necessarily part of the IEP, they still should be measurable and should certainly be educationally relevant and must be related to the goals that are in the IEP. These goals aren't required by federal law, and so most school districts actually will not include short-term objectives in the IEP, but there are some that might. So there are instances where they might be written into the IEP, and they're usually written to be achieved in less than 1 school year, so monthly, quarterly, etc. So moving on to IDEA Part C. Part C provides early intervention services for eligible infants and toddlers birth to 3 years of age and their families. So IDEA Part C provides infant-toddler services in natural environments, in homes and daycares. Services must be family-centered, they must be developmental, and they must be provided in natural environments. And natural environments are defined as settings that are natural or normal for the child's age peers who have no disability. These can be any place where a child participates in activities and routines that promote development. So this can include a home, a child care setting, a park, a community center, a local swimming pool, a grocery store, and more. Now, under IDEA Part C, the child's services and goals are documented in the Individualized Family Service Plan, or the IFSP. And the IFSP is developed by the team. The team is usually the service providers as well as the family. There's typically a service coordinator involved. IFSP goals are reviewed every 6 months and rewritten yearly. So whereas IEPs are reviewed every year, IFSPs are reviewed every 6 months. We can make changes to the IFSP at that 6-month review if necessary. If we don't have changes to make, we can just continue with that plan and then wait and actually rewrite the plan at the yearly review. The IFSP must include a present level of development, a statement of family resources, priorities, and concerns. Remember, this is a very family-centered, family-driven document, and so family resources, priorities, and concerns are very important. Measurable outcomes, and in this model, outcomes are determined by the family and based on what is important to the family. So therapists can certainly offer their expertise and guidance to families, but ultimately, outcomes are written based on what the family wants. And outcomes in the IFSP are not necessarily discipline-specific goals. They're usually more broad and related to, overall function. But again, they're really driven by what the family wants. The IFSP must also contain a statement of early intervention services, the natural environments where the services will be provided, as well as the transition plan. Children transition from Part C services to Part B services on their 3rd birthday. So in Part C, every IFSP review includes discussion and development of a transition plan. So what does the PT contribute to the IFSP? Well, as I mentioned before, the IFSP must be family directed. So all of the goals and outcomes listed in the IFSP are based on family needs. And again, the PT can certainly provide guidance and expertise and suggestions for the family, but ultimately it's up to the family to decide what they want from their Part C services. And if we do make recommendations or provide guidance to the family, we have to make sure that we're consistent with information obtained in the family interview, that we focus on strengths. So we want to be very strengths-based, focusing on what the child can do and will do versus focusing on what they won't do or can't do. We want to use lay language. The IFSP is really meant to be a very family-centered document, so we want to use language that the family will understand. And we also must be flexible so that we know that if the family's needs change, we can change the IFSP and kind of change our approach. Outcomes in the IFSP focus on activities and participation. So these are not impairment level goals. You're not going to see goals about increasing strength or range of motion or even balance. We're going to focus on activities like walking and sitting and eating, and participation like going to the park with family or playing with their sister. So those are what the outcomes are going to focus on. As I've mentioned several times now, they're going to be based on family needs and concerns. They're determined by the family in collaboration with the service provider. They're multidisciplinary. They're not necessarily PT goals. They can be child or family focused. They're written to be achieved within 6 months to 1 year. And they may develop, you may develop short-term objectives for best practice, but similar to IDEA Part B, short-term objectives are not part of the IFSP. So if you develop those short-term objectives, you're going to keep those in kind of some supplemental documentation. Sorry. So overall, when we look at Part B and Part C goals and outcomes, we see some common themes that arise. They are determined in collaboration with the child, parent, teacher, and or other team members. They should be related to functional skills. They should be focused on participation and activities. They should be realistic and achievable, and they should be easily understood and free of professional jargon. And you've probably seen this before, but when we're looking at writing objectives, and again, this can be in Part B or Part C settings, we want to think about writing objectives that are SMART. So SMART stands for specific, measurable, attainable, routines-based, and tied to a functional priority. Our goals and outcomes should include a behavior to be achieved. So this is the who and the what. When and under what conditions the behavior will be achieved, and the criteria for success. And so a lot of times I will tell students and new therapists to think about the third word rule. When you're looking at developing a goal, you want to say, you know, Johnny will what? That third word of your goal should be really the meat of what is it that you want them to do. And again, in IFSP and IEPs, this has to be a functional activity or participation based. So you're not going to be talking about impairment level things like strength and range of motion. You're going to be talking about participating in PE class, or carrying their lunch tray, getting on and off the bus, playing with their friends, walking to the park with their family. All these are the types of goals that you're going to write. But just because you're writing these really functional goals doesn't mean that we can't be very specific about what's in them, and that they can't be really measurable. So this just gives some examples of some outcome statements. And so I would suggest that you pause the video here and look at these different outcome statements that may be stated by a child or a family, and think about how you could write activity or participation-based goals that would capture these outcomes. So I want to be able to get my lunch tray by myself and sit with my friends at lunch. We want Natasha to be able to do craft projects with the other kids. I want Sue to be able to listen to story time. We want Johnny to be safe in the classroom and at school. We want Eliza to be able to play with her friends. So these are all outcome statements that we may hear from children and families during IEP and IFSP meetings. So as I said, go ahead and pause the video and think about ideas that you would, for goals you would write for each of these. And I've already created a list of potential goals for each of these outcome statements, but some of them are good goals and some of them are not so good goals. And so again, I want you to read through these different goals, and I want you to think about whether they're, quote, good goals or bad goals, and think about, if they aren't such a good goal, how you might rewrite the goal to make it better. And again, you're looking at SMART goals. So you want to make sure the goal is specific, measurable, attainable, routines-based, and tied to a functional priority. So just a few overarching principles about documenting visits in educational and natural environments. We want to be family friendly and person first. So we don't use the terms client or patient. We use the term child, or we just use their name in documentation to make it really family friendly and person first. We need to write our documentation in lay language. And we don't ever in these settings do discharge summaries. We write discontinuation or transition summaries, or we even may write a conclusion of an episode of care, but we don't ever talk about discharging children from these services, because we recognize that these disabilities are lifelong and may require kind of ongoing services coming in and out of the child's life. A couple of principles that are specific to early intervention and school-based settings. In early intervention, visits are documented on a standardized form to be shared with family and other professionals. So a lot of times you'll be writing your documentation on a sheet that you'll give a copy to the family, or you may even be inputting that documentation into a computerized system that the family may have access to those notes later. So again, we want to write this documentation in terminology that's really recognizable to family and professionals that are not PTs. And early intervention documentation should capture interventions performed to achieve IFSP outcomes, progress towards achievement of outcomes, family input, suggestions for the family, and a follow-up plan. In a school setting, we document all strategies, interventions, staff, student training and education, communication with students' parents, with the student's parent or guardian, and community-based services. And progress is to be reported at the same frequency as it is provided to children who do not have a disability. So frequently with school-based settings, we actually will send home quarterly progress notes about physical therapy, similar to those quarterly grade cards that kids get. So this is a sample of a note, a physical therapy visit note that may be written for a early intervention, a child seen under IDEA Part C. And take a moment just to pause this video and look over this note and see what you think may be the problems with the note. Looking at this note, you can see that there's a lot of jargon. We talked about balance X on a T-ball, lots of abbreviations, head and trunk writing. This is very jargony, sat in high chair with insert times 10 minutes while performing bilateral UE activities. So just lots of jargon and lots of abbreviations. This is going to be really difficult for a parent to understand. Here we say patient's mother is to remove patient from high chair if midline posture is not maintained. Head, neck, trunk deviate greater than 15 degrees from midline. That seems like maybe that might be difficult for a mother to assess. And we've also, we keep calling it the patient in this note, which isn't very person first or family friendly. And then it's also very impairment based, so lots of discussion about head writing, degrees of postural control from midline, dynamic standing balance. So just lots of, it may not be a bad medical note, but this is not an ideal note for an early intervention setting. So let's look at what that note might look like if we write it a little bit better. So first of all, we start by really tying the documentation to the IFSP. So we start by saying, talk to the mom about IFSP outcome number 2. And that's that Max will participate in mealtime with his family. And so then we go right into the discussion of what the family thinks and then response to that family's input. We can see that we've given the family a lot more clear and jargon-free instructions on what they're going to do next time. And then under family comments, questions, and concerns, it looks like we've done a little bit better job of actually addressing that concern. So rather than just saying, Mom is concerned that he can't walk on the playground, so I'll come back in 2 weeks and we'll work on that, we actually left something with the mom to try between visits and have a plan to meet at the park to address that. So this note overall, I mean, it's just much more family friendly, free of jargon. It's much more child-centered. It's tied to the IFSP outcomes and tied to the family's function and really participation based. And so it's still very professional and very physical therapy related, but it just looks, it's just written in a different way. And finally, I just wanted to show you this table, and this gives just some kind of comparison contrasts documentation in pediatric settings, including medical settings, early intervention settings, and educational settings. And so you can kind of just take a look at this chart and you can see kind of comparing and contrasting the different settings, and this is just going to kind of reiterate some of the things that I've talked to you about in this video. And then finally, this slide has some different references and resources that you may want to access if you're interested in learning more about pediatric documentation. And with that, this concludes our discussion of pediatric documentation.